Good evening, everyone. I'm presenting on my study on comparison of macular and peripapillary microvascular changes in migraine patients and controls. Migraine is the third most prevalent disease worldwide. They can have migraine auras, which are sensory symptoms. 70% of the patients experience migraine without aura, and the duration can be between 4 and 72 hours. And the complete pathophysiology remains elusive because of the complex interplay between the neural and vascular factors. It has been proposed migraine as a potential contributing factor to ischemic complications of retina and optic nerve and increased risk for and progression of normal tension glaucoma. Immediate and sustained alterations in ocular perfusion makes them susceptible to ocular complications. There has been studies showing vascular differences on comparing with a healthy population in OCT parameters. So we intended to evaluate macular and peripapillary microvasculature and structural changes in patients of migraine with aura, without aura, and controls by OCTA. We did a prospective observational study. Institutional ethical committee clearance was obtained. We included 100 eyes, 32 eyes of 16 patients with aura, and 36 eyes of 18 patients without aura, and 32 eyes of 16 controls. We excluded patients with neurologic disorders, optic nerve and retinal pathologies, and systemic conditions which will affect the microvasculature. And healthy controls on vasoactive medications were also excluded. Best corrected visual acuity, anterior segment and posterior segment evaluation, intraocular pressure, OCT, OCTA parameters were all recorded in all patients, and OCTA images were analyzed using Angioplex matrix software on Cirrus HD OCT model 6000. We analyzed foveal avascular zone, foveal and peripapillary flex. Here flex is a novel metric which gives number of red blood cells moving through vessel segments per unit area. And also we analyzed ganglion cell layer thickness at macula and peripapillary region by OCT. We used independent t-test to test the significance of difference between two independent groups, and ANOVA test for more than two groups, and p-value less than 0.05 was taken as significant. We analyzed 100 eyes in three groups. The gender distribution, intraocular pressure, and mean age was equally distributed in all the three groups. And we found that foveal avascular zone in patients, migraine patients with aura and without aura was significantly larger when compared to controls. And the macular perfusion in superficial capillary plexus was found to be significantly lower in migraine patients with aura when compared to the other two groups. And no significant difference in peripapillary perfusion was seen between all the three groups. Also, there was no statistical difference in macular ganglion cell layer thickness, GCL thickness in superior, inferior, and nasal peripapillary region. However, we found significant thinning of temporal GCL in migraine with aura and also without aura patients. So foveal avascular zone was enlarged in migraine patients both with aura and without aura. The microvascular ischemic events or capillary remodeling during attack may be the cause for this enlargement. And this finding was seen in other studies conducted in Turkey and USA. And foveal vascularity in superficial capillary plexus was significantly decreased in migraine with aura patients. This finding supports it is a retinal microvascular disease, and it can be related to increased risk of ocular complications in migraine patients. And temporal peripapillary GCL thinning was seen in migraine patients. The repeated insults due to reduced blood supply during the attack can result in structural changes even during the attack-free period. These findings might provide insight into association of migraine with optic nerve diseases such as anterior and posterior ischemic optic neuropathy and normal tension glaucoma. Majority of studies have shown structural and microvascular changes in aura patients. However, in our study, FAS enlargement and temporal peripapillary GCL thinning was equally significant in migraine patients without aura as well. The limitations of our study were smaller sample size, and participants were in interictal period, and duration of symptoms of migraine was not included. To conclude, there was significant FAS enlargement and temporal GCL thinning in migraine patients with and without aura, and there was reduced foveal vascularity in migraine with aura patients compared to other two groups. These findings can be basis of establishing link between migraine and other retinal ischemic diseases, and it could help us better understand migraine's pathophysiology. Based on the study, there is a potential avenue to embark on extensive longitudinal investigations, including duration of migraine episodes, acquiring scans during the attack phase, and incorporating more comprehensive array of parameters. These are my references. Thank you.
So when did you do this documentation of FAZ, and did you do the OCT in these patients during the attack of migraine?
No,
or once it resolution of that attack?
in the resolution period.
How many days after that? Because usually it lasts for 72 hours.
Yeah, ma'am.
So
But
how many days after the attack of migraine you did this study?
ma'am, no specific period, ma'am, because patients were presenting like within 1
I
or 2
think it's
days.
important. It's a reversible disease, you know. So whatever changes, they disappear. Because in ophthalmoplegic migraine, they have shown that there's an enhancement of the oculomotor now, and it becomes all right.
Yes, ma'am, that's the
So
limitation.
because was exactly not no neurological, it's a neuronal phenomena. Later on, it results into a vascular event. You know, spreading wave of excitation followed by wave of depression, that results into there is upregulation of trigeminal system. So I think how much relevance it has, you know.
Yeah.
My question.
And how many attacks, is there any difference the patients who get many attacks of migraine, the one who get very less attacks of the migraine, that should also be studied, you know.
Yes, ma'am.
Okay.
My question to you is like when the patient complained of the aura symptoms, what symptoms did you find in your study? Which specific aura complaints?
Scintillating scotomas, ma'am.
Scintillating scotomas. In what time frame did you collect all these 18 patients of aura? In how many, months or whatever? How
Most
m-
patients were presenting within days, also within weeks, many patients.
What is the time period of your study?
2 months, ma'am, we did.
In 2 months, you got 18 patients of aura patients.
Aura, yes, ma'am.
Difficult to get.
Yeah, it's very
get, you know.
difficult
Common migraine is much more common than classical migraine.
present.
Okay, that's a good attempt. Okay.
Thank you, ma'am.
Any other question? Oh,
So I have one question for
no?
you, sir.
Okay.
So you told that migraine is the third prevalent disease
Ma'am.
worldwide. The first slide.
Third more prevalent disease, ma'am.
So among all the diseases, that is the third most.
Most prevalent.
Okay. So do you have any disc suspect? Did you rule out or you included in your group? You have talked about IOPs. All the groups had intraocular pressure.
Yes,
But you
ma'am.
didn't talk about the disc suspect or glaucoma suspect.
Ma'am, we excluded all retinal
glaucoma suspects.
Glaucoma suspects, ma'am.
How foveal avascular zone is related with AAON or NTG? Your finding is foveal avascular zone is less.
Foveal avascular zone, ma'am, and also peripapillary GCL thickness was
Only temporal GCL thickness.
GCL thickness was less, ma'am.
Okay, thank you.